on their editorial board, so I have a little bit of bias, but the point is I balanced out our team, a study team comprised of other university members, heads of various pharmaceutical companies, no bias there, of course. But first and foremost, I'd like to talk to you a bit about what big data is. It represents an incredibly large amount of information. It's characterized by different types and sources of information, and it's really the utility of big data is driven by specific and rapid information processing. I'm sure you all have heard the term big data. I can't escape it. There's friends of mine who have titles in corporations with big data behind it. Director of big data. It's just, I predict next year or the years to follow, the new buzz term will be fast data, because it's sorry, I have a bad sense of humor, but to make big data effective, you need it in real time. It has to be hardwired to work. For a lot of decisions you'll be making in your lifetimes, especially with predictive models on maybe identifying high-risk patients, you have about 30 seconds to make that decision, and it's important to have the data harnessed in such a manner. The big data represents an incredibly large amount of information. Kaiser Permanente, they have a variety of sites throughout the United States. They manage more than 4,000 times the amount of information in their databases than what's housed in the Library of Congress. I'm trying to shock and awe you here. The amount of data in the world for healthcare is expected to increase 50 times by the year 2020, and to 25,000 petabytes. Petabytes approximately the size of all the information in all the academic research libraries in the United States. Can any of you guess why this is increasing so much? What type of data is out there that you work on your computers and your phones daily as you communicate with your friends and family, let's say, not email, Twitters, one gentleman in DC tweets a lot, Facebook, all these different things. All this information is being gathered, and it's actually going to be, exactobytes is going to be the new term we're going to use in the future, because there's a lot of data out there.
But that wouldn't be healthcare data, though. Is that part of the healthcare data, the Twitter and the Facebook?
It's going to be. In fact, I was just going to speak to that. It's coming up. There's a lot of interest in gathering that data. As I'll sort of discuss here, back in the 90s, we looked at big data in terms of terabytes. I have terabytes on my computer. You know, I think I do. I do. You know, that was basically SAP or Oracle, things like that. Now we're looking at measurements in petabytes, which is digital asset management. We have a lot of imagery on databases and so on. And in the very near future, if not now actually, we have the YouTube video. I binge on that all the time to get information. Facebook, Twitter, more imagery, like PET scans, all this kind of stuff, 3D imagery, all this stuff is being used. It's a lot of data. It's also characterized by diverse types and sources of information, so it can be structured or unstructured. So in the realm of healthcare, data can include BMIs in terms of your weight and height, urine samples, genetic mapping, pictures, or listing of symptoms. Sources of big data in healthcare are many and varied. There's electronic medical records, such as EPIC, which is used by OSF for the last four or 5 years. Over 70% of hospitals in the United States use EPIC. It's very expensive, but it's very popular. Had you had stock in EPIC some years back, you might be considering another philanthropy vocation or something. People did very well. There's wellness programs, there's health risk assessment programs, clinical programs, disease management programs, census data, medical and pharmacy claims. I do a lot of work personally with medical and pharmacy claims data. I also do a lot of work with electronic medical records. All this stuff, which I'll talk about later, is available at a price to buy and to answer unique questions asked by pharmaceutical companies and like those people who can afford this data. Let's just put it there. The IT programs for information technology are asking specific questions, so they're capable of seeking specific patterns, providing practical utility to the data collected. So such a platform includes the development of appropriate preventative care, interventions, and highly individualized treatment regimens in complex therapeutic areas such as oncology, and the ability to make computations at very high speeds as necessary to allow you to make the generalized knowledge applicable in clinical practice. You've all heard of Watson, IBM Watson. That's being used for oncology decision making now. It's incredible. The companies keep changing names, keep getting bought. But I think it's either Optum or another company which basically bought the data from IBM to use and sell to pharmaceutical companies alike. It's big business. So big data represents an entirely new paradigm in data analysis. The traditional approach back in the day, they had structured and repeatable analysis where business users basically determined what questions you'd ask. The IT people back in the day, not too long ago, would structure the data to answer the question, and you would be an executive in a corporation. You'd be getting monthly sales reports, profitability analysis, and customer surveys. Whereas now, the whole big data approach is iterative and exploratory analysis, where IT now delivers a platform to enable creative discovery, and businesses explore what questions can be asked in terms of product strategy, preventative care, and so on. I did a project before I came to Peoria over 5 years ago for 3M, and they asked me to create a set of economic evaluations associated with this technology that they had in McDonald's in these places, whereby, I don't know if you've been to these places where the screens magically change when you walk by. They kind of know, they sense who you are, and they kind of cater towards what influences you. So there's all this kind of data working behind the scenes. I found that just absolutely fascinating. There's a lot of components of big data. I have to tell you about the 4 V's. There's volume, velocity, variety, and veracity. Volume is the terabytes or exabytes, as we're going to call them in a few years, if not now, of existing data to process. Velocity is the streaming data, milliseconds to seconds to respond. That's pretty important. There's variety. There's so much data in so many forms. There's structured, there's unstructured, there's text, there's multimedia, you name it. There's veracity in terms of data in doubt. There's uncertainty due to data inconsistency, and a lot of data is incomplete. Ambiguity occurs with agency, deception, and model approximations. It's real messy sometimes. So structured versus unstructured data basically comes from a mix of unstructured and multi-structured data that comprises the volume information, whereby unstructured data comes from information that is really not well organized or easy to interpret in terms of databases such as Twitter or tweets, as they call them, and other social media posts, but they're working on that. The multi-structured data refers to a variety of data formats and types that can be derived from interactions between people and machines. So I'm kind of rushing this. I realize this will probably be a half-an-hour presentation, but we have a lot of time for questions. I like questions. So the traditional approach in terms of structure is the standard reporting, operational metrics, quality core measures, and clinical insights. The new approach for unstructured are clinical notes. For a lot of HIPAA concerns prevent doctors' notes from being read in databases. They're parsed out. It's frustrating because there's a lot of good information there. Medical imaging is very important. As you get MRIs, PET scans, all this kind of stuff. It's important to have in a repository, database and use. There's just a lot of imagery takes up a lot of room. And then consumer behavior and preferences, as I mentioned earlier, when you walk by those large displays at a McDonald's or fast food restaurant, they seem to magically change and try to influence your decisions. Compliance management is important. The components of big data initiatives in terms of sources of data, well, there's large static amounts of data that are susceptible to leakage and tampering. It's very much a concern. In databases, consortiums, which I'll talk about briefly, are all-in-one repositories, and they're useful for data stewardship and governance and policy making. All amounts to big data, basically. So stewardship is important because you have to have some way of managing the acquisition of data, how you store it, how you aggregate it, how you de-identify it for HIPAA concerns. Quite often, data we get is de-identified. That means any chance of knowing who the patient is greatly reduced. I say that because I used to work for the Canadian government, and we had a Minister of Health who at the time, this is well before big data was concerned, she decided to talk about a particular rare disease state and the individual in a community. Well, with rare occurrences of diseases, in a small community in Alberta, Canada, you're going to have a pretty good idea who that person might be, and that was very embarrassing. So even for a minister to say something, it's probably best not to. So a lot of governance and a lot of strict policies come about from mistakes like that. In terms of governance, the process by responsibilities of stewardships are conceptualized and carried out. The qualification for users, ownership. There's all kinds of owners. There's individual investigators like ourselves, myself and a large group of individuals here in Peoria have worked with I&I, with the MS Clinic, and created our own MS flowsheet registry for the last 3 years. It's one of the, sorry, I'm so biased. It's a very good database. A lot of people are seeing it as that. So it gives a full clinical picture of the patient, which is quite remarkable because we found, for example, if any of you aspire to be a neurologist and you're seeing a new patient or even a returning patient, sometimes it takes 6 months between visits and there's a lot of information that you have to go through. Well, this particular flowsheet registry gives you the full picture of the patient, and what one neurologist said to me, this is not scientific, what would have taken him an hour, he can do in 15 minutes now with all this information at his fingertips. So we like to think there's some reduction in burden there. There's healthcare providers, managed care organizations, there's government-sponsored and public-private partnerships, which I'll talk about later. So there's all kinds of components involved in considerations for data consortiums. There's the type of software you use, there's the selection of techniques in terms of statistics, there's the business of alerting your users, and there's all kinds of systems to help aggregate the data to a central repository, such as this. This is the Agency for Healthcare Research and Quality, AHRQ, and it basically goes, here we are, we're authorized users, we had our training, we had our security clearance and so on. We pass through a message to the coordinating center. They then issue a project-specific query, because we can't possibly touch the data, because we're not worthy of it, of course. Sorry, I'm tongue-in-cheek. There's a common query system, which leads to a project-specific query, which involves a variety of firewall-restricted repositories, such as the inpatient data warehouse, ambulatory electronic medical records, payer claims data, inpatient EMRs, registries, and future data resources. And all that basically works in concert and returns back to the coordinating center to help answer a question. Complicated, but logistically a nightmare, I would say. The day by which all this data is integrated, that you and I can do it without using all these barriers is a while from now, I'm sure. The FDA has their Sentinel initiative, which is a distributed database whereby the user here submits their query in a computer program. The data partners retrieve the query, and then the data partners review and run the query against their own local data. Data partners review the results. Data partners return results via secure network, of course, and they go back into the results being aggregated and back to the user to work with.
So, Dr. Asche?
Yes, of course.
In a case like that, are they typically asking for like a fixed file, basically? So are these people going through their own EMRs and finding structured data and then returning it in a flat file or whatever kind of format, I guess?
Well, sometimes you get a CSV file back, which then you can run in your SAS programs or Excel or Stata or whatever you use, but there's no hard and fast truth here. You're not necessarily going to get the data back to work with yourself. Quite often, and I'm trying to keep a straight face here, quite often folks like myself and the group I work with are restricted from accessing the data. There's security and regulatory measures. Oh, yes?
Isn't the rationale for that they don't want hackers to go in and install ransomware and then so that they put barriers, physical barriers, so that
I agree. I agree wholeheartedly. It's also, there's some trust issues. Regulatory folks, lawyers, do not like you going into their databases, and I deal with that with the ethics system here. They used to let me go on a dedicated server there, which had a statistical package resident in the server, and by Citrix, I was able to access through a dumb terminal without any computer, just a keyboard terminal, run queries. Then any results or anything would be run, and the report would be generated by the hospital, and then maybe I'll get a printed copy of it from them. But the point is and they can turn off the switch anytime, basically, if they don't trust you. I'm giving that's an extreme, but regular people are also pretty concerned about you running in and running your own queries too. Hackers, of course, you don't want hackers going in there and dropping their little gifts in there, and I understand. Any other issues that you see with why you would have to have a database set up here? Keep in mind, there's many different data partners, right? This is just an example of two. Okay. Do you do analysis? You seem to know the lingo.
I'm like very cursory.
I'm just curious because yeah, you do get CSV files.
Mm-hmm.
I think that's what you get.
Yeah, that makes sense.
So there's a variety of components in big data initiatives. I'm going to be talking about the paper shortly, but I wanted to give you sort of a flavor of big data. There's types of analytics. There's the evidence-based way of telling us what happened and probably why, which is descriptive. There's predictive, which is very, very important for healthcare decision making because it helps build predictive models, which allow you to see what's happening at maybe a rate better than a flip of a coin. You can say with some certainty. You can predict better. There's prescription. There's it tells us what to do about it and empowers healthcare decision making. So there's a lot of upswing in terms of the growth of healthcare analytics. Hospitals and the like are hiring a lot of people because there's a lot of work to do. There's a lot more data to work with. I hate picking on local hospitals. Let's say another hospital across the state. They're overburdened with requests. Their people can't keep up. So the time it takes to get a query done or analysis is a lot longer than it used to be because there's a lot more data and a lot more interested parties. Access is improving. What I described to you were somebody who's not part of a hospital can access it remotely is quite interesting. Having a dedicated server, which they would have to pay for with a statistical program resident, is how far you can take it in terms of a regulatory person being a little bit concerned about who am I and why am I interested in their data. They're worried that I'm going to look at everything, which is a concern, I suppose. It allows your power to compute to improve. Clinical trials themselves are quite limited. They're not really the real world necessarily. They're protocol driven, and the inclusion criteria kind of limits their generalizability. There's a need for more effective clinical decision support. So the origins of the need for big data in healthcare really stem from the management of rare diseases, so that nearly 5 or 7% of Americans have one of the 7,000 diseases that healthcare professionals consider care. A hospital in itself doesn't necessarily have the number of patients that you can do meaningful research, so you need to work with other systems, other databases to gather the numbers you want. Oncology is a good example. There's all kinds of cancer types and subtypes and multiple treatment options. All these can benefit from a comprehensive data collection and processing system. So there's a lot of, in the cancer realm, there's a lot of big data initiatives underway. Memorial Sloan Kettering, Johns Hopkins, MD Anderson, American Society of Clinical Oncology, ASCO. They reset collaborations. They work with a variety of IT providers. Google's in the game, IBM Watson, Toshiba, a whole variety of groups. So data as it's available includes an ever-growing repository then of clinical, genetic, social, outcome, and claims information. Now we have an opportunity then as healthcare professionals to improve patient care through assessment of treatment effectiveness, not necessarily the efficacy that is clinical trial based, but effectiveness in terms of how the real world sees things. Outcome prediction, you can almost do it in real time now, which is remarkable. Hi. Sorry. And there's a lot of challenges in realizing the full potential of big data. Unique partnerships are occurring across the industry, medicine and research, with data issues specific to validation, linkage, and access. All these things need to be addressed. So the issue of data validation and linkage, this is where we wrote this paper. We see it as a problem. There's a lack of complete and linked information available. A lot of groups which say they're integrated aren't. Their databases. We have to understand better why the data exists and how it colors our interpretation. We need to have confidence in each data component's correctness and accuracy, because that's paramount when we do analysis and then render important decisions. There's missing, lost, and unavailable data. This won't ever end. There's a lot of all kinds of errors involved. They're just missing from our research arsenal. Why that's important is a lot of these data points, if they're not available, that kind of interferes with our ability to assess certain interventions and public health outcomes, because once you have data missing in terms of a particular important component, there's not a lot of sense in integrating anything if there's incomplete data for that particular variable of interest. I can give you lots of examples, but keep in mind, a lot of, for HIPAA concerns, a lot of data is parsed. Doctor's notes, a lot of things are parsed. So we're not working with it. Yes, sir. We're not working complete data sets anyways.
Has the advent of like blockchain affected the way that like big data is considered in the future, I guess?
What was the first part?
Has like the advent of blockchain,
Okay.
has that affected the way people are viewing the future of big data for healthcare at least?
I don't know. I don't know how people are viewing the future of big data for healthcare, but it's important. I don't know, I kind of end with that, with all the, sorry, but it's, there's a lot of data that's unavailable. Key information on the patient progress and outcomes. A lot of people over the age of 65 are excluded from commercial databases. A lot of people, it stops at 79 in a lot of cases, because we're not supposed to, as you get older, you're really identifiable. However you want to argue this, it's a way of removing ability to identify. There's other reasons too. I'm sorry. That's the simplest one for me, because there's a lot fewer people in that age bracket, but I can't get the hard and fast explanation for data companies why they stop at 79, but they do. So if I do 65 and above, a lot of times I'm not going to true of employer databases, because most people are retired at that point anyways, but other commercial claims databases, I'm not quite sure, but it comes up every time. There's a lot of times specialists are in electronic medical records, such as the GE Centricity database, the Geisinger Electronic Health Record database in Pennsylvania. A lot of them do not include specialist care, so I can't really tell what a psychiatrist is doing necessarily, or a physical therapist, or, I mean, these things come up, and it's troubling, and a lot of data can be lost too. There's a model that has 6 spheres where bias can happen. One is the propensity of the patient to access services, the propensity of the doctor to detect, treat, and record, community and system-based factors, factors associated with the processing and storage information within the secondary database itself. All kinds of biases to worry about. There's unmeasured and confounding, where when you interpret results, you have to address unmeasured confounding. There's a lot of very smart people out there who've worked out strategies to address confounding, such as multiple imputation, propensity score calibration, instrumental variable approach, looking at unobserved errors. There's use of external validation data. There's a lot of very clever people working on this. There's all kinds of strategies out there to support data validation and linkage. Some variable definition changes reduce granularity. Others can introduce standardization rate for comparison. You all know that we're moving over to ICD-9, from ICD-9 to ICD-10. The whole business of mapping, cross-mapping has come up. That's important for reducing bias in cohort discovery and all types of comorbidity algorithms that we consider. Researchers such as Boyden and his colleagues have created tools to help translate, so it's all happening. You have to be able to match with greater precision, so evolving methodologies allow us as researchers to improve the stringency of matching against observed patient populations. That allows to help us better simulate randomization. There's a promotion now of linking populations in terms of data variables, whereby stakeholders themselves have now invested in creating system-level data warehouses. We have data warehouses here at OSF. The Big Pharma has big data warehouses, all experiencing various levels of success. You can't buy everything, you know. You just have to hope and wish that you get what you need. Sorry, I'm saying that from my experience. I worked in Big Pharma for many years with 2 major pharma companies, and we spent a lot of money buying databases, and we were always trying out new ones, and you know, we had a limited budget. And then those of you who work in pharma have to understand that medical affairs and marketing are 2 different parts of the organization. Believe it or not, the money we spent on databases and medical affairs for health economics and really interesting work, marketing buys on their own budget. Prescription counts and so on, data that we use, we don't talk to each other, so the money runs out pretty quickly when you have 2 people in the same organization spending loads of money. Somebody takes notice of that. So you can't necessarily get the databases you want because your spend is limited. But there's a lot of databases and registries across the globe that are available to us, which we use. The Clinical Practice Research Database, the MEPS, the Medical Expenditure Panel Survey, National Health Registries in Nordic and Scandinavia, the ACS NSQIP, which is a surgery database, which technically I guess we could use here. A couple of the surgeons seem to have passwords and access to it, but they're not giving them up. Here's something, I don't know if this is gonna, oh shoot. I really wanted to talk about this. The International Society of Pharmacoeconomics Outcomes Research, that's a group of about 14,000 individuals, members. I'm a member. I also chair their International Classification of Databases Initiative. This has been a 3-year project where we're looking at thousands of databases all over the world, and we're putting into a very user-friendly electronic platform which you can navigate. It describes everything you could possibly want to know about the database, but every 6 months we have to revisit it because information becomes redundant, because companies buy each other, databases expand, they buy other databases, they're constantly on the move. What I wanted to do, actually I think I can do this. I wanted to show you an example of our oncology database, because this is something I kind of like, but we stopped work on it a few years ago because the new initiative which I'm leading, which I presented a couple years ago in Vienna, Austria, is very close to being launched. So whatever I'm going to show you now is nothing compared to what we're going to have going now. But the reason this is important is because researchers all over the globe need to know what's available in their respective countries. And this organization kindly put a budget together to help pay for making this happen and maintain the database for years to come. I'm really afraid to go into the hyperlink because I'm going to lose this presentation altogether. What do you think, George? Should I just try?
Yeah, I think you can.
Okay, here we go. Goodbye to presentation. Yeah, I do use Macs. I should know that. A double click should. Oh, it's awake. I don't think this is going to work, and I'm not too worried.
Would you like me to bring this up?
Because these slides will be made available to you. You can go through. Basically what this is a platform which allows you to search for seminal publications related to oncology, economic cost evaluations, clinical, and so on. Allows you to search for databases anywhere in the world, and also in terms of key findings and so on. It's really good. But what we're doing here, in this group here, which actually in May I present in Baltimore where we're at, because by the end of this year, the deal is we have to be finished and launch our new platform, which is going to be good because it's going to be a database of databases. In fact, today I just entered the MS Flowsheet Registry, which I talked to you earlier, own creation, because I wanted a spotlight on it for multiple sclerosis research. So I had my conversation with OSF, and I like to talk as though they're here listening to me. And they're all concerned, well, Carl, we're not going to share our data. And I'm going, I'm not going to share your data. I'm just going to describe what we have here. And we're going to tell the world that we do great things in Peoria for a flow sheet registry that can help improve the clinical picture of MS patients and do better research. So anyways, I put all that together, and I'm having the leadership review it to make sure it's okay to put onto this website. But what's important here is examples like that. These are databases which you otherwise would never hear about. So as a researcher, you can Google and you can go through all these vendors and so on and think you know what's out there, but quite honestly, once you look at our platform, you're going to know everything. And it's going to be revisited every 6 months, and it's not going to be redundant. And those of you who have, I spent a lot of time in school doing a lot of dissertation and thesis related topics. Those of you need those shortcuts to get the data, get free data, so you can do your thesis without bugging your supervisor to pay for it. That being said, other types of researchers want access to the data. Pharmaceutical companies have very deep pockets. I've worked on projects, many projects, which they paid about $150,000 just for a data cut, just to answer one question. And my God, I know, but that's not uncommon, and it's going to get worse because few groups now have learned how to integrate electronic medical records with claims data, and that's going to be the holy grail. Sorry, I'm being tongue-in-cheek. That's going to be expensive data because now you're going to have claims in terms of medical and pharmaceutical data, plus lab tests and all this other stuff combined with costs. We'll see how that works out. But this is not data anybody in this room, maybe Dr. Gromlich, but certainly not myself, will ever get my hands on because I don't know who's going to pay for it. But that's where we're going. Actually, I knew this was going to happen. See, once I touch a hyperlink, maybe I can, oh, I'm sorry, it froze. Thank you. Oh, there it is. See?
Oh, it's here.
It's there, but it's not there.
Yeah.
Okay. So it wasn't that bad. Okay, thank you. Thank you. And thank you, George. So the issue of data access, this is a question then who has access to the information. The key components of access include who owns the data, security and privacy, cost and availability. A lot of database registries have governors, a group of people who decide who gets access to it and so on. It's quite critical. A lot of partnerships now are being built between public and private organizations to help researchers' abilities to access data. There's all kinds of strategies out there to support data access. Remember Joe Biden's Moonshot program? Okay, well there's all kinds of campaigns out there for public support and understanding. There's a lot of sustainability funded research, risk assessment plans, and establishment of distributed data networks. I could go on and on. In this paper we publish, it's all written up. George, that was attached to the invite, right? I encourage you to do that rather than hear me talk verbatim out of the paper. It's there for you to read and review. So as we wrap up, the IOM vision in terms of high quality or high value care is driven by rapidly improving science. So as the science improves in terms of the culture, the leadership and incentives, the evidence improves and the care improves, thus impacting patients, clinicians, and communities alike. So in conclusion, there's opportunities to accurately assess treatment effectiveness and outcome prediction. This is exciting. We can realize the potential of these data sources and draw accurate conclusions, but careful thought is required as you look at the data. And there's all kinds of solutions to data access challenges. A lot of them are in flux right now and have been for some time and will continue in the future in terms of who owns the data, the security needs, regulatory concerns, and cost is a big barrier. As data improves, it gets better, people want to sell it. And that kind of wraps up where I'm at, and I'm more than happy to answer questions. This is more of a paper that we wrote because people need to know just how limited things really are. I've heard politicians, I've heard people in high-ranking positions say everything's great. I always thought the Moonshot program was there. Somebody had said everything can be resolved through databases, and clearly that was not the case. Please, I'm willing to answer hopefully any questions you might have, and go at it. Oh, yes, sir.
So I'm a gastroenterologist, and in 20, 30 years ago, when we would do research, we would look at our own patients, pull out the charts, get data, and now people go to big data and analyze stuff, and it always is sometimes you wonder when your own charts have so many gaps that you cannot fill, how legitimate and dependable is big data, where someone is listed as gastroesophageal reflux,
Yeah.
but the testing may not totally have confirmed it, but since it's in a database, we are taking it as a holy grail truth.
Well, actually.
And I just wonder
Yeah.
how do we synergize that? Big data is here to stay.
Here's my thought. Our frustration with national databases is that they're incomplete and not everything's there. The MS Flowsheet Registry, which I feel like I'm boasting about, but we just did that because we recognize there are so many gaps. Epic can only take us so far. The extra information that the neurologist said they wanted were various motor assessments, reasons for discontinuation of drug, a variety of different information, which quite honestly is not readily available in Epic. So I'm not saying it's a holy grail, but it's pretty complete because now we're adding patient-reported outcomes. There's talk about in the future genetic work and so on, imagery and all these type of things, which lend itself to maybe answering questions. I'm thinking more so from the perspective of a clinician who has to assess prior to an examination how the patient's doing. But from a researcher's perspective, all this information is very good for predicting things, predicting a relapse, or however you want to phrase it.
So even the data is a database as good as the one who is entering the data, you think it's
Yeah.
still reliable enough to predict and make decision making since the numbers are large?
Dr. Gromick, were you going to answer that?
Well, I was gonna
Oh,
reflect on that question, because
Yeah.
I had the same question you do, but I guess we made the assumption because healthcare economists or statisticians that when the data sets get large enough, you can measure the variability of the data and get a variance, and then use that variance then as a weighting factor and say, okay, I'm going to put this into my mathematical model that I'm creating to predict something, but because I know the variance is large, I'm going to put a weighting factor that lowers the weight of that particular variable because I know in advance that it's lousy data. And then something else may be very accurate, and then that may have a higher weighting factor.
Yeah.
And I assume that's how you do it.
Well, I'll give you an example. Gosh, I feel like I talk about this a lot, but maybe not in this forum, which is good for you. In predictive modeling, I can get a C-stat maybe 70 to 80%, which is remarkable. That means I can basically figure out a high-risk individual based upon a whole series of variables which are available in databases. However, I don't have their socioeconomic status. If I had that information, I probably could get 90%, only because that's a huge predictor, but it's just not something we capture in databases. So I know that's not answering your question, but the granularity of the data, as I described, is something I would be more apt to harness locally and not expect it on a national basis so much. I don't know about the variance aspect, but for rare diseases, like I said, there's over 7,000 diseases which are considered rare occurrences here. And at a local level, we're just not able to get the numbers here. I can think of so many examples where we have to use big data and look at multiple centers. So I praise big data for that. In your clinic, not so much.
No, I agree. I mean, I work with rare diseases with
Yeah,
the RDC,
yeah.
RN, and you know, you're absolutely right. There's so many rare diseases that less than 200,000 people afflicted with it. That this is the only way to get it. But at the same time, in the rare disease I work, we have a contact registry where the patients are putting their information. But we know that unless somebody validates it, it is what they think is going on.
Yeah, that's the problem.
Yeah.
Patients putting their own information in. There's recall bias. There's all kinds of stuff going on, right? I can't remember what I ate yesterday, and we're expected a patient to tell us? I really can't. Yes, George.
Really quick comment. Would you like me to pull up the database while you're answering questions for people to see?
It's okay.
Okay.
If you want to distribute the slides,
We will.
it's
definitely.
there.
Okay.
I'm not shamelessly promoting it. I'm just saying, this fall I will. I'll try to send an email around saying, look at this. Because we put 3 years of work into this. And I have hundreds and hundreds of people working with me all over the world. I have one guy in Scandinavia looking at 22 databases for me right now, because for language barriers, no, I'm just kidding. They speak English over there, you know. But there's all kinds of things going on that, if you're a global researcher for a big pharma company, you're gonna love this. If you're a student in the United States, you're gonna love this, because it may have taken me a year to figure out I had to gather all my data prospectively because the databases weren't out there when I was a student. I don't want to spend a year. I just want to know then and there, okay, what's out there. So I have a student working with me from John Hopkins, Elizabeth, and she's feeling the pain as a PhD student right now and says, I wish this was available when I was looking for databases. So as medical students, you may not care so much, or faculty. Well, you do care as faculty. Yeah, of course you do, because you probably want free data, right?
Were you talking?
Oh, whoever wants to talk.
I just wanted to ask, could you speak a little bit more about the integration between claims data and EHRs? Why is that significant? Because at least in my thinking,
yeah.
like they should be saying the same
No,
thing, or no?
no. Yeah, okay, think of, sorry, I understand where you're coming from.
Mhm.
Think of, so I worked in this arena so long
Yeah.
in claims data,
Mhm.
medical and pharmaceutical,
Mhm.
lab test information,
Mhm.
all kinds of tests and so on are absent.
Mhm.
So I can't really, if I was to do I'll use an awful example, pulmonary function tests, I could probably tell you, yeah, they were taken, but I couldn't tell you much more at that point. I couldn't tell you what Feb1/FEC ratio we're dealing with. I couldn't do any of that to help in a COPD study. Quite honestly, a lot of information is not even uploaded into systems here, I've noticed. So, sorry, I get excited, sorry.
No, that's fine.
But, it's a holy grail because pharma is going to pay a lot of money for that. That's why people, sorry, I think that's what motivates vendors to create such things.
I think one of the things too, and that's related to bridging claims and clinical data, but in addition, bridging clinical data between sites and stuff like that. And you've made some references to kind of the idea of being able to link an individual across multiple, whether they be like levels of care or sites of care or anything else. I guess, where are we maybe nationally with having unified linkers like that, given the idea that, like, you know, a social security number couldn't work because you have immigrants without social security numbers? And then do we require legislation, I guess, to do
Oh,
that?
I don't know about legislation, but granularity kind of ends when you leave the healthcare system. So I can't really track you when you go across the street, or community point to OSF, vice versa. But CMS can give us that data, and we can, a certain percentage of patients, we can kind of track them. I'm really not at liberty to say this because I don't really understand it too well, but the Central Illinois Health Information Exchange, which actually is the only one left in the state now, and I'm on their board, they claim to be able to have everything in terms of following patients around and so on, but
How did they do that?
Oh, they work with all these various different hospitals and they contribute the data. I don't necessarily believe it, but the point is they're getting funding, you know, they go after this and granularity and following people. Kaiser Permanente, I worked with their offices in Portland, Oregon. They also have offices across the country. It's not integrated. They have 8 million patients, but it's not.
Really?
It's not like that. I'm Canadian, in case any of you care. Canada prides itself on having data. It's international truism that in Manitoba, all the hospitals are linked in real time. It's incredible. That's Canada, though. That's Manitoba. But the point is, there are efforts being made. The Canadian Cancer Centre Network has somehow linked all their cancer centers. Whether or not they follow a distinct patient, they probably don't jump around. But the point is, it's really cool what they're doing up north. And sometimes good things come from the north. I'm hoping to see some of that down here. It's just so darn complicated in the United States. I've worked down here for close to 16 or 17 years. And when I moved here, I was so intimidated because all my colleagues said, "Oh, you guys, you got this understood." I realized in 6 months, I caught up. Only because it's just so complicated. And it's not integrated, and we often had to travel all over the country to have collaborations and partnerships with different groups, because when you're an organization, I won't say who, but you don't really want to see evidence from other plans or organizations. You want to see evidence using your own individuals within your group. That matters. Quite often I created default values using national data to try to influence maybe Kaiser or Regents or some group like that. And they really wanted to see their own data in there, but they just didn't have it. It's difficult to harness data like that. So I'm not going to digress any further. I'm just saying it's hard to be convincing to groups which want to see their own data in the models that you're using. They won't necessarily give it to you. So you give the model, it's a double-edged sword. You give the model, then they put their own data and say, look, you look lousy, you know, in terms of the outcomes. But I won't digress. Yes, George.
Question about security and analysis of all of this. First question on security is, you mentioned a lot of the newer developments in big data have significantly reduced the probability of so someone, you know, is trying to steal data from that
Or
database.
plant things like Dr. Cronlich said.
Yes.
Nasty.
Exactly. Or, yeah, plant those things.
Yeah.
Is there still any small probability that, you know, someone could re-engineer, let's say, a patient's profile from even de-identified data? Because I've heard of other instances in terms of genomic data where like a hacker in the experiment was able to reconstruct a patient's identity even from a de-identified genome.
Yeah.
Is this still a possibility in these secure databases?
George, I'm not naive, but nothing would surprise me these days, given all the hacking and influence hackers have on all kinds of things, right? And genomics, why would they do that? But I guess maybe for trials or something? Sorry, I'm trying to think of a reason.
Sure.
I can imagine what the reason might be, but I hope that's not it. Yeah.
And a second question about analysis of this data. Where does artificial intelligence and machine learning, this new resurgence coming up, where does that fit into all of this?
Well, there's a lot of people coming out with degrees from a variety of institutions in that discipline now, and attracting a lot of attention in hospital systems. I've just touched upon a couple individuals here that are doing it. And I also work with people when I used to live in Salt Lake City in the University of Utah before I came here 6 years ago. I work with people doing it there. I know it's important. I know it searches for data. I understand, and it aggregates it. I understand that. I don't understand how well it's doing. Does anybody else know how well machine learning has helped improve the quality of our work? I hear a lot of people telling me it's great, but
I mean, I mean, I feel like it's still in its like infancy as far as being able to like do the things that I think the things that are valuable, which is real time, like results and predictive analytics. But I think they're doing a lot of cool stuff. The advanced analytics team at OSF has done a few different projects. I'm sure you're kind of familiar with like the ejection fraction project, and I'm working on a homelessness project that kind of like involves learning how to read natural language and stuff like that.
Wonderful.
There's a lot of good
Probably the future.
I think future, yeah.
Yeah.
Definitely.
It wasn't so long ago when genomics was in infant stages. Not that long ago, I would say within that 10 years ago, where people were just talking about how wonderful it would be to, and a lot of folks we're working with here, even in Peoria, want blood work. They want all this for predictability, for looking at things as well. So it's expensive. That's all. Yes.
So kind of building off of the idea of improving predictability, and also tying in what you were talking about earlier, how Canada has linked, multiple centers to share data.
Flags.
What are the major barriers for hospitals in the U.S. or healthcare systems in the U.S. Preventing them from sharing? Because I'm thinking about Methodist and St. Francis. They're across the street. They're both on Epic. They have the same service area and patient population.
Yeah.
You would think that they would better service patients by sharing their data.
Yeah. Fierce competition, I guess. I'm not being facetious. They sue each other. I mean,
I guess
Dr. Gromit?
you read about the fact that Methodist sued OSF for restraint of trade. And it all had to do with that contract from Blue Cross Blue Shield. And so there's no love lost between the two organizations. And so they share things. They tried to share, 15 years ago they tried to share laundry services. And they even argue about that. And so now they can't even share laundry services. So it's the competition.
I find I'm very I&I centric for MS research. Why? Because they let me. I don't think if I started working with, sorry, I don't mean to hurt anybody's. If I started working with Unity Point, I don't think I'd have such a good relationship with OSF. I don't know. It remains to be seen. I do work with Unity Point, but not on their data, just through projects that they're interested in. So it's I agree with you wholeheartedly. For the betterment of the community, yes.
I think we can take a couple more questions before we wrap up.
Oh,
Okay. And then I guess one other question I had, kind of again going off of how you were talking about claims data and EMR data, merging those being the holy grail. We're currently seeing like a burgeoning of tech companies collecting health data, and hospitals are trying to catch up. But I haven't really heard anything on the EMR side of EMRs trying to implement apps to mine that data. And I'm thinking it from like a future clinician perspective. I think it would be great, say a patient has been having like a steadily increasing blood pressure, heart rate over a few years, and you want to implement lifestyle change, and you can use fitness trackers and apps to see how they're, whether they're compliant with lifestyle change or whether you're going to have to start medication. So there seems to be a lot of value in that, but I don't really see, I haven't yet seen, I guess, momentum in that direction. Do you know anything about that?
Well, yes, I do actually, because I sit on the Mayor Review Panel at NIH. I have for 3 years now, which looks at mobile health issues, apps, and all the studies from sub-Saharan countries, because for regulatory purposes, we can't do that stuff over here. So I'm told, because I can't figure out why the PIs are American and the countries are in sub-Sahara, but it's because of our environment here. I don't know if you agree with that, but that's what I'm getting at this big table of very influential people telling me that. California, you can't use these apps. Sorry, I can't give examples, I don't think you're supposed to, but I think it's regulatory concerns. They actually brought a lawyer in to talk to us about. Does that make any sense to you? Because that's the way I see it.
There was a call for applications several years ago to see if mobile applications could be used for influencing healthcare outcomes. And my understanding is that money has been spent and studies have been done, and I'm not sure that there's no answer yet.
Okay, because they give out $20 million grants
Right.
for that type of work, and they're using phones in Kenya, or they're just doing it throughout the country on monitoring pregnant women having certain issues and so on. It's all important. I have a lot of apps on my phone for healthcare, but I'm not sure any of them fit the
See,
bill.
one I remember reading about
Yeah.
was the, I think a Fitbit study,
Yeah.
and it's looked to see if it actually changed people's weight, getting that feedback.
Yeah, yeah.
Not, people just don't change their behaviors.
It's not working for me. I'll tell you that much. But, sorry. Yeah, I hear you. Any more questions?
I have one about publication.
Yes.
So if you pay for data, or you're gifted some to do some study,
Yeah,
and you generate some cool findings,
Yeah.
and you generate a paper, you go to publish that paper, it gets accepted. What happens to that raw data? Does it get dumped into one of those repositories, or can?
okay. I'm gonna ask a question where I think you're asking it. If you buy the data, you have what's called a rider agreement with a data vendor, and it stipulates what you're looking at, for how long you can look at it. Once it's over, you can't use that data anymore. If you're talking about another scenario, I didn't pick up on that.
So I'll give you some pretext for it. So I did some next-gen sequencing
Okay.
work in my previous life.
Yeah,
And part of the requirement for publication was dumping the raw data into GEO, the Gene
Okay.
Expression Omnibus.
Sure.
It was publicly available.
sure.
I don't know why that is, if that's a consequence of have a federally funded grant. It was human tissue generated through microarray data.
Yeah.
So I guess where I was coming from with that was having those data publicly available, facilitates, more generation of more data. It allows people to go in there and do their own studies based on their
Yeah.
little bits of data. And B, I think it facilitates replication, right? So if you were to publish something, and then the origin of the original data, if that company or whatever says, or hospital says, you can't make that data publicly available, then how is anyone supposed to replicate?
I knew you were gonna say replicate. Yeah, that's a good one. Yeah, I don't know, in terms of,
So, but
Yeah.
may I ask also, can they do that? Can they say you can publish it, but no one can see the original, the raw data?
I don't know.
I know, I can only speak from my experience, in that what you're saying is exactly true if it's NIH funded or
Okay.
federally government funded, because in the last few years, they've put that as a new requirement.
Yeah.
Like, so my last NIH grant application, I had to state what was my data sharing plan
Okay.
up front, so that, because the government says, well, we paid for this data, and now you're the one that can use it? That's not right. You're gonna de-identify it, and then anyone can use it, and then they pay once and then have it recycled.
Yeah.
But,
Because I don't
private
know for
companies are not
all
like that.
journals, but
Yeah.
certainly some journals make it a requirement to
Yeah.
dump your data in a
Well,
public repository.
yeah, I'm not sure. There was the day, back in the day before big data, you kept your files from your trial in your garage for 7 years. Yeah. But I'm not sure about the
Okay.
electronic realm where you give it, I'm not sure. That sounds like you need a legal mind behind that one.
I don't have any of the data. I was just
Yeah,
curious.
yeah.
what would you advise with the young ones in the room on using big data? How do they go about using big data? They're going to be faced with it.
Well, that's just it. Even the free service we're offering, classifying all databases, the reason so many people are working with us because they want to sell their data, right? There's a lot of free databases out there, but the granularity and the quality is not so good sometimes. When you pay a premium, if the Holy Grail were to exist with claims and electronic health records, you pay for that. Because it's going to influence a lot of people.
Also in terms of as they become residents and they are
Yeah.
fellows and they do research using their
Yeah.
EMR.
You
should
work
they
with us.
With their IP.
You work with us. Yeah, because we created a flow sheet registry for multiple sclerosis for that purpose, to work with students and residents. Whenever I get to speak before I&I, the whole idea was the residents to come in there and say, yeah, we want to work with you. There's 22 of them, right? So it's evident if they're going to say, well, there's no databases to work with, we're going, here we are, but it's nothing wrong with the data locally here. Good.
Thank you, Dr. Ashe.
Oh,
Did you have something?
No, I have nothing more to say.
Thank you.
And you can distribute that slide kit if you want, and the paper you have. And I'm very easy to reach. I'm in the basement in the tornado room.